All right, we'll go ahead and get started. Thanks everyone for being here today. I'm sure people will be trickling in as we go. Thank you to SMARTfit for hosting this amazing opportunity and webinar for us. The title of today's webinar is addressing MCI, ADLs, Parkinson's, and more with new assessment and training technology. We'll introduce our speakers. Mike, why don't you go ahead and introduce yourself?
Great, thanks, Ryan. Mike Studer, physical therapist and board certified in neurologic physical therapy. Been a PT for about 31 years and hailing from outpatient rehabilitation here in Oregon. Glad to be aboard today.
Thanks, Mike. Rob, please introduce yourself.
Thank you, Ryan. It's great to be here. I'm Rob Winningham. I'm a professor at Western Oregon University. And for the past 25 years, I've been studying human memory with a focus on older adults and ways to maximize and improve memory in older adulthood. So this is a topic that's near and dear to my heart. I'm looking forward to sharing this with you all.
Thank you so much. And my name is Ryan Glatt. I'm a certified personal trainer, health coach, and I have a master's in applied neuroscience. I work in an outpatient clinic alongside clinicians and rehab clinicians to integrate dual task exercise programs for individuals with cognitive and neurological conditions. It's my honor to present alongside Dr. Winningham and Mike, as well as working with the SMARTfit team. Everyone over there is amazing, and we're just thrilled to be delivering this webinar today. So our presentation objectives are presented here. We're going to talk about the growing scientific evidence supporting the value of technology-based cognitive and dual task cost assessment and dual task training, and how new technology allows us to implement these interventions successfully, be able to track them with standardized assessments, documentation, and provide diverse cognitive and physical demands, as well as multi-domain training programs. And we're going to overview the ability of technology that can help assist us in identifying the appropriate cognitive and physical challenges for all ability levels, and then talk about how we provide these demands in order to meet them at that ability level. And then we'll also talk about the essential role of gamification to engage, motivate, challenge, achieve, reward, and get results faster. So we're very excited to present this information to you today. I think as we look at these solutions, we also have to look at the problem. And per the title of our webinar is indicative of is the global prevalence of cognitive decline. There's about 69 million cases of traumatic brain injury in the United States, 50 million cases of dementia, and 10 million cases of Parkinson's. That's per year. And then the global prevalence in percentage of MCI, or mild cognitive impairment, is 42% in individuals over 60 years of age. Cognitive impairment of Parkinson's affects about 40% of individuals with Parkinson's disease. And there's about 15% of dementia cases are attributed to traumatic brain injury. And even though we're talking about Parkinson's, MCI, TBI, dementia, we know that it even spans outside of that. There's subjective cognitive decline, individuals who are post-stroke, which makes up a significant aspect of the neuro-rehab field, if you will, and individuals that just want to slow down the cognitive and physical aging process, which is essentially everybody. And in addition, looking at performance, and we often think of performance just in purely in terms of athletics, but certainly performance for these populations as well. Even if there isn't a diagnosis of some sort of neurological condition or cognitive impairment, it does behoove us to bring in performance principles to these populations. And so we're very excited to announce the SMARTfit technology. If you're here, you probably have heard of it to various degrees. The reason we love the SMARTfit platform is because it's aligned with science. It's a part of completed, ongoing, and planned funded studies in a variety of populations: pediatrics, Parkinson's, stroke, mild cognitive impairment. It's built on the well-established literature of cognitive motor dual tasking, which we will outline today. And there's extensive cognitive motor assessments that we will also outline today that is very unique to the SMARTfit system. What we also like about it is that it meets the market needs for customized programming, physical distancing, baseline measurement, and more. And there's a robust proprietary technology platform that's cloud-based, video-enabled, and CE UL certified. So we'll watch a very brief video on the SMARTfit system.
SMARTfit brain health programs offer a fast track to significantly enhancing the mental and physical performance we use in everyday life. This is achieved by using gamification coupled with a technique known as dual tasking, which is the simultaneous combining of cognitive and motor tasks. The SmartFit's user-friendly app provides instructors with an extensive library of pre-filmed training activities designed by industry experts. They are easy to customize and can deliver excellent progress and baseline reports. SmartFit's gamified activities are easy to learn but challenging to master. This sets up the perfect conditions to fire up the brain and trigger fast neurogenesis at any level. Each set of categories addresses multiple domains of the brain while also offering unique cognitive, motor, cardio, and specific skill-building challenges, all designed to improve and accelerate brain health and physical competence. Here is a quick summary of how they function. Rally games focus on ball playing skills and place demands on processing speed, open-ended decision-making, and visual perceptual abilities. Track categories activate targets sequentially to place demands on visual search, sustained attention, and response time. The Seek games are multiple choice games designed to place demands on selective attention, visual search, decision-making, and inhibitory control. Chase games light up a single target sequentially, but if it's not touched within a set time, it will move to another location. These games improve processing speed, inhibitory control, and response time. Lights out games turn on all target screens simultaneously, and they have to be put out as fast as possible. They improve processing speed and open-ended decision-making, as well as visual perceptual abilities. The memory category includes 14 different memory games designed to train or test short-term memory and visual spatial working memory. With equations, the center target asks the question and the others provide multiple choice answers. These games train speed of processing, certain aspects of executive functioning, and decision-making under pressure. Spelling games scroll a word across the center target while the other targets offer multiple choice answers as the word is spelled out. Our exciting new cognitive motor test category delivers a set of cognitive motor tasks designed to be taken as baseline tests. These provide individuals the opportunity to track changes in their cognitive and motor competence over time. SmartFit's programming, now cloud-based and protected under HIPAA regulations, offers participants the ability to access their personal programs and data from any SmartFit system. This makes it easy to offer standard programming across multiple locations.
All right, lovely video from that was voiced by the CEO of SmartFit, Kathy Lamberti, who is here with us today. Kathy, I think you should give guided meditations a try as a career path. Great voice. So now that you have a great overview of what the SmartFit system's programmatic capabilities are, you can appreciate how we'll present dual tasking assessment and training. Certainly, we want to create as many options as possible for not just meeting people where they're at, but training this thing that we call cognition, which really allows us to interact with the world around us. And because the world itself is so variable and so complex and unpredictable in many ways, we also want to reflect those principles in our training programs. And too often we're a little bit limited in the programmatic or cognitive tasks that we're giving individuals in what we consider traditional dual task or exergame interventions. These are often very limited. And so this is why one of the reasons we're so excited in working with SmartFit is because the broad application and all the domain-specific approaches that we can take with the system. So let's talk about the principles of dual tasking. We're going to define dual tasking in just a minute, but it's probably known among all of the presenters and attendees today that exercise has myriad benefits to the brain and the nervous system. And this one of these articles by Netz et al., I believe is Lori Netz from Israel in 2018, created a review study about what might be the differential effects of different types of activity on the brain. And so when we have physical exercise, cardiovascular exercise, resistance training, that constitutes this category of physical training or fitness. And we know that leads to global neuroplasticity and the mechanisms associated with global neuroplasticity. Talking about angiogenesis, the creation of new blood vessels, neurogenesis, the creation of new brain cells. And we know that this concept of global neuroplasticity is not maybe specific to regions of the brain. Certainly there's been research showing that it affects many regions, global gray matter volume, the hippocampus, the temporal lobes, the prefrontal cortex, but it's not task specific. On the other hand, we have motor training. These are neuromotor activities, sports, dance, martial arts, and mind-body activities that drive task-specific neuroplasticity through the mechanism of complexity, whereas physical exercise drives global neuroplasticity through intensity, both of which can improve cognitive function both through shared and unique mechanisms and pathways. The unique opportunity of dual task and the unique opportunity of SMARTfit is that we can get the best of both worlds. So Mike, why don't you define dual tasking for us, now understanding what motor and physical training is?
Sure. Yeah, thanks, Ryan. So dual tasking is the simultaneous performance of two tasks that can have different goals, separate goals, and distinct responsibilities, so that it's not just necessary that two tasks are done together. For example, if I'm walking and carrying a backpack, you might consider that's doing two things, but that's just increasing the complexity of the single task of walking. A dual task requires that definition be met, that the two tasks are absolutely discrete and have different goals. So actually walking and bringing that backpack from around my back to opening it up and pulling something out of it would be a differentiator and put us into the category of a dual task.
Awesome. Thank you so much. And so let's talk about the concept of cognitive reserve. We're going to come back to that relevance of the definition of dual tasking and also its categorical place within motor and physical training, the integration thereof. We have this concept called cognitive reserve, which could be at a fundamental level understood as your mental gas tank. And the more full this gas tank, the more cognitive vitality and brain vitality you will get. And so there's various ways we can look at cognitive reserve. We can look at it in the context of normal aging or accelerated aging as seen in dementia. We could also look at it when there's a neurological insult, such as a traumatic brain injury or TBI, or other acquired brain injuries, such as a brain tumor or a stroke. Then there's hopefully a recovery period that is appropriately aggressive and time-bound, such that we can maybe come up to this place where we're back close to this trajectory of normal cognitive aging or slightly reduced, as we can see by the arrow of loss of functional reserve. And then we want to try to offset the environmental and age-related factors that may accelerate this trajectory. So we want to manage this the best we can. And so in the interest of doing that, not only are we looking for multimodal interventions, exercise being one of the most powerful, but perhaps more powerful combined with nutrition, stress management, sleep hygiene, cognitive stimulation, social isolation. We'll review some of those interventions, but also making these interventions more potent. If we call exercise a poly pill, if exercise is a neuro poly pill for the brain, how would we make that poly pill more potent? Combining it with cognitive challenges, social stimulation, enjoyment, these are all things that might create a more potency for this pill that we call exercise. And we believe dual tasking can do that. And certainly the research.
Quick things to say on that one, Ryan, if I
yes,
could.
Please.
Yeah, so our listeners would probably identify very well with cognitive reserve, especially when you consider the analogies to a physical reserve. How close are you to actually experiencing an injury if you are an athlete? How close are you to actually being completely out of endurance and energy? So if you think about the concept of aging and frailty, if you have built up a reserve of strength and endurance and fitness capacities, if you have and experience an illness such as a viral illness with COVID-19 and you are hospitalized, how close are you to achieving frailty may depend entirely on how robust you were before experiencing that threatening illness. Another big thing to say about this, and is important to understand that the SMARTfit platform is a differentiator from the cognitive stimulation tasks that you might have been used to hearing about in the order of 5 to 10 years ago, where we thought just doing crossword puzzles and other cognitive stimulating activities would be enough to help us build our cognitive reserve and preserve our capacities with subsequent losses that accumulate with aging. What we'll find out later in the presentation, and a little sideline now, is that generating some of your own memories and own iterations of facts and events and other things that you can pull out of your brain without novel problem solving that Ryan is talking about actually don't protect you as much as we might have thought 5 to 8 years ago. Thanks for allowing the interruption, Ryan. I appreciate it.
Yeah, absolutely. And I think it's worthwhile, since this concept of cognitive reserve is more complicated than we thought, and some of the things that we thought were the most potent or powerful ingredients maybe aren't. And so it kind of leads us to ask the question, what is maybe the most potent? What really matters here? And I think there was another paper that just came out this year showing that level of education may not matter as much as we thought. It still matters. And then other things such as the Mediterranean diet being helpful. We don't want to make this about diet, but that maybe there is no safe level of alcohol, for instance. I'm sure many people are upset to hear that. So we're learning more about what matters the most and what matters at what level, what confidence level we may recommend or not recommend something. But certainly there's this emerging science of dual task that we'll explore that is there's a reason so many smart individuals, clinicians, and researchers are turning their attention towards it, is because it's showing great promise in the context of other things that we've considered to be hopefully helpful for cognitive reserve, like crossword puzzles, but maybe aren't really turning their head as much as we hoped. So Mike, why don't we talk about what dual tasking interventions traditionally possess, but what they really should possess if they're going to have the greatest efficacy?
Yeah, that's a great point. I'll try to remain succinct on this, and I'll tell you the typical dual task tests and screens that we have are fashioned so that they can inform us something about, is this individual at physical risk? Typically, we look at fall risk. Were they to engage or interact with a complex environment, something that requires their attention multidirectionally or at least bidirectionally? So typical screening and testing just looks at the physical component. And Ryan asked a very salient question there that I'll attempt to answer. What we're trying to do to differentiate and what they should require, the tasks that are designed to inform us about dual tasking, is they should inform us about much more than just the physical characteristics. They should also inform us about the level of cognitive participation, the cognitive accuracy, and many items that I'm very excited to bring to you tonight that you're going to see in the video that we share with you about dual task testing: reaction speed, reaction time, and many other things that relate to that. So we should be informed, maintaining that physical importance, but also understand what this individual's performance was on a cognitive level, which is clearly not done well in today's body of knowledge.
Very good. Thanks so much for that perspective, Mike. And with that said, let's go into dual task assessment and look at, we define what dual tasking is, but we talk about dual task assessment and dual task training. So if we could, I'll get away from this busy slide until we need to get there before we define the basics here, but what is the difference between dual task assessment and dual task training?
Wow, that's a really important one there too. And when we create a dual task assessment, we're looking at something that offers standardization, has some psychometric properties, and something that we can baseline off of. It doesn't actually have to have true functional relevance, real world relevance, because we need to be able to establish this individual's performance compared to an established baseline normative data pool. However, dual task training should be able to afford something that's very personalized and very individualized based on the user's preferences, their gamification tendencies and desires. We'll talk more about gamification in the future. Maybe even have a little bit more functional relevance and can involve maybe even a little bit more novelty and de novo design as we're working in programming. Assessment needs to be clean, reliable, and clear. Treatment can be very personalized, functional, and also allow for that creativity.
Absolutely. And so when we look at dual task ability, somebody's ability to dual task, whatever that assessment may be, we know or we've heard of attention skills, memory skills, perhaps executive functioning skills we're familiar with. Is dual task ability one of those skills? And how is it relevant to those other domains? We don't have to get too deep into it. But
yeah, and I'll be happy to hear from Dr. Winningham on this as well. I'm going to weigh in and say dual task is actually a complex interface of many of those skills. As we heard Kathy eloquently narrate on the video, we also heard about inhibition, problem solving, selective attention, and all those things are absolutely part and parcel in any one or a myriad of the dual task assessments and interventions that we can provide. So dual task itself, it really gives us an umbrella that we can select a different cognitive attribute or property to be responsible for, or we can actually look at the integration of many of them.
Yeah, and I would just add that it's domain specific. Executive functioning is a large category. There's many different types of executive functioning cognitive abilities. So just an example, if somebody could have a discrete brain injury, the prefrontal cortex, and they have damage to their ability to inhibit a behavior or a thought, that's going to be really hard for them to do an inhibition activity on the SMARTfit console, for example, while dual tasking. But yet their ability to maintain information in working memory might not be as impaired. So, the types of cognitive activities that we choose may be dependent on what the individual needs to improve on the most, and that certainly would affect their dual task cost.
Awesome. And what I'm hearing is because dual task relies on so many of these cognitive functions, cognitive functioning, even though we can target domains, is actually very integrated and complex, that dual task itself, both ability and training, may be more real world. And that's been one of the criticisms of cognitive training and cognitive assessment, is that maybe it's not so real world in all cases. And this is one of the pressures of all interventions targeting the brain, is to be more real world, to have ecological validity, to have far transfer. And so in the interest of doing that, we're going to talk about two conditions that are very prevalent: Alzheimer's disease or dementia. Of course, it depends on what kind of dementia, but we'll just go with the most common type, which is AD, Alzheimer's disease, and Parkinson's disease. Mike, can you explain this slide to us and how dual task assessment and ability is reflected in these two conditions differentially?
Great. So Ryan, when we're combining dual task with a motor task and another cognitive task, and the reason I say it that way is you can combine two separate entities of cognitive tasks and use different aspects of cognitive function, as Dr. Winningham said, domains. But in this situation, where in SMARTfit application, most of the time we're going to be combining a motor task, be that reaching, stepping over, sit to stand, walking, moving, turning, with a cognitive task that Kathy already outlined and we've been talking about throughout the entire presentation, which can be scanning, calculating, spelling, and many others. So when you look at the left and right halves of this slide, you're looking essentially at the attentional and executive resources in the gray half, and we look at those being a little bit less available as the diseases of dementia, mild cognitive impairment through dementia, progress. So if you look at that as a resource pool that you have that is diminishing. In the right-hand side of your slide, in the white section, you look at, again, primarily motor effects of Parkinson's disease. We also recognize Parkinson's disease and Parkinsonisms as having non-motor and having cognitive syndromes as well. But if you look at the cognitive resources and the motor resources as being essentially separate, you can understand when we use dual tasking, we can prodromally detect early preclinical, make a detection of Alzheimer's and Parkinson's disease, because dual tasking requires the effective combination of both of these. Having a deficit in either resource pool will show up in dual tasking.
Fantastic explanation. So not only should we be looking at how different conditions, whether it's prodromal or diagnosed or progressed, respond to dual task assessment and training, but we should understand that the mechanisms are different, that perhaps it's not as easy as neurons that wire together, fire together, although that may be one of the principles we employ to do the work we need to do, but it's complex in that it's going to be individualized. And so we do need this broader spectrum of cognitive and physical tasks and a better understanding of probably what's going on up there, which is continuing to unfold. We're continuing to understand it. So thanks for that explanation, Mike.
Thank you.
And let's talk about these shared abilities or impairments. It could go either way. It's really a spectrum from impairment to ability in the variety of neurological conditions we've discussed. We have activities of daily living, we have, or ADLs, we have gait or walking, we have balance, static, dynamic, reactive, and cognition, in which we've defined several different subtypes. So Mike, and for Rob, it would be great if we could comment on the intersection and carryover of all these different domains. We typically isolate them. Why might we want to consider addressing them, and how are they connected in these neurologic conditions?
Yeah, I'll go first on this, and I'll tell you just straight from a physical therapist who has worked for more than 30 years around occupational therapist as well, I will tell you that if an individual has some selective functional decline or impairments that lead them to need assistance or extra time or cues with their ADLs, you understand that by borrowing more of our overall resources to process your activities of daily living, we also subtract away from finite resources in cognition. I have to concentrate more on sequencing because things aren't coming automatic to me. I have to be able to concentrate more on the application of perhaps a compensatory approach of putting my left arm into a shirt first. The same is holding true for gait. If my walking is completely isolated, protected, safe, and functional, I don't have to think much about it. I don't have to share some resources of cognition over to pay attention to that my right foot does not scuff against the ground, or I don't swing my right leg out to the side, or how to negotiate and sequence my assistive device of a front-wheeled walker or a single-point cane. So if gait is doing its own job, it doesn't steal from cognition. And for the same reasons, an individual who is returning back to field of play, pitch, court, diamond after a concussion, and they don't have quite the highest level of balance compared to what they had to offer that sport, which is a very high level demand in most sporting instances before their concussion. Now they're also borrowing from the realms of cognition. And so my ability to recognize where my left forward is and where my center is, or where a defender is, actually has to be borrowed against, because I'm losing some resources because my balance is not automatic at this point.
Fantastic.
When I see this slide, a couple of things pop out. The overlap between ADLs and cognition, we've known for over 10 years that there's a very strong correlation between particularly executive functioning ability and ADLs. And what we think is happening, if we can improve executive functioning, one of the things that's really nice is it does generalize. We get far transfer. If we get an overall improvement in different domains of executive functioning, it transfers in, and that would predict more independence and greater ability to do ADLs. And similarly, like Mike was talking about, and this ties in cognitive reserve, if we can improve cognitive reserve through training, through physical exercise, so there's a slide later that shows a lot of different ways to potentially improve cognition and executive functioning, that gives a reserve for balance and gait. So people are less likely to have problems in the future, and that can be targeted. That's something you probably would want to do with Parkinson's disease, for example, and their prognosis would be much better if we improve their cognitive reserve.
Absolutely. And I think when we're looking at both in the context of rehab and in fitness, if I'm working with an individual who has a physical or cognitive impairment, and perhaps they've had a traumatic brain injury or a stroke, or they're just going through the aging process and they want to slow that cognitive trajectory, one of the biggest concerns is balance and then confidence during gait. I think it's not really appreciated how much cognition plays a role in all of that. In addition, perhaps people focus more on cognition, neuropsychology, speech therapy, sometimes occupational therapy may focus on cognition and ADLs, but not understand or appreciate the influence of gait and balance and the relationships between all of these things. And so wouldn't it be great if we can train all of these things simultaneously, if not within the same technique? Certainly it's hard to check off all four, but if we can take on movements and cognitive demands that do generalize across all four, that's a big win in terms of saving more time and perhaps being more effective. So let's briefly introduce some of the current strategies, at least for mild cognitive impairment, but we know this is true for Parkinson's, for stroke, traumatic brain injury. We know these interventions in these considerations are helpful for improving cognition and quality of life and mood in all of these populations to varying degrees. We can't necessarily give the prescription here, although there's some general ones as ACSM and the Physical Activity Guidelines for Americans 2nd edition highlights. But let's talk about some of these interventions. Mike, do you want to briefly go over these?
Sure, absolutely. And I think it is very straightforward for all of us. We know that exercise at least 3 times per week, 20 to 30 minutes of walking at moderate intensity has been shared as a dosage. And Ryan, you did a great job of summarizing the ACSM down there as well. Exercise, as Ryan actually alluded to earlier, gives us the opportunity toward angiogenesis, brain-derived neurotrophic factor, neurogenesis, and then also synaptogenesis from exercise. And as Ryan did a great job of alluding to, it gives us that general effect. We also understand that when we look at mood, that our relative availability of neurotransmitters and neuromodulators is important. So when we can engage someone in an activity, a sport that is meaningful, productive, fun, and exciting for them, that we have the ability to be able to help the individual with mild cognitive impairment perhaps guard or shield themselves a little bit from some of the deleterious effects of depression as well, because we know depression will in fact be subject on the individual's cognitive capacities as they decline. Nutrition is pretty straightforward, at least with the science that we know it to date. Right now, we've always looked at, certainly Mediterranean, different fish oils have become positive and not quite as attractive over periods of time. But we really understand some general principles of health, staying away from sugars, etc. Cognitive training that we've spoken about obviously has some specificity, and especially with what we're looking at too. And as much as that can be done with leveling to the individual, an item that we haven't talked about so much, giving them an opportunity to be challenged right at the level of their capacities, which we're going to touch on a little bit more, is helpful in cognitive training. So stimulating, novel, multimodal, all those things that Ryan touched on as well. Sleep hygiene, plus or minus 7 hours or so per night of quality sleep, very helpful. Obvious reasons for the individual with mild cognitive impairment is consolidation of memories and the ability to be able to actually, this is so fascinating, create a dishwasher-like effect of some of the plaques and negative proteins that can accumulate in the brain, which may sound a little bit odd, but that's exactly the time during sleep that the cerebrospinal fluid comes in and cleans out some of those negative and deleterious accumulative proteins. And then finally, medication management, looking at the effects of controlling hypertension, controlling hypercholesterolemia, and many other things, including the depressive tendencies as well.
Fantastic. Go ahead, Rob.
I was going to say, I wrote a book, an academic book, on how to maximize memory in older adulthood, and we had a chapter on every one of these. If we were to update it for 2021, we probably need a chapter on yoga, which is actually dual tasking if you think about it, because there's a physical component and there's a cognitive component. If you're focusing on your breath and whatnot. Meditation, although the meditation probably would be better if it was done by Kathy, there's significant effects there on executive functioning. Every one of these that's up there, nutrition does get messy. That's the messiest one, but every one of these has studies out showing correlations with executive functioning. The greatest number of studies are on exercise, probably followed by cognitive training. It's interesting though, we talked about mood, because mood, depression and anxiety puts people at risk for memory problems and cognitive disorders. But some studies have actually found cognitive training alone can improve mood. Certainly there's a physical exercise mood effect, but the cognitive training and mood effect, we found this in one study we did, and we hypothesized in that paper that it actually could have been improved inhibitory abilities. If you can turn off negative thoughts, then that can improve mood. So this is really exciting research. And I liked how I'm reminded it says MCI, current inventions for the management of MCI. It's probably management of many conditions, but I want to point out mild cognitive impairment is probably the most treatable. We see that in the literature. You can get the greater gains with these types of interventions because you don't have as much brain damage. The hard part is, we have people coming in with mid to late stage dementia. The prognosis isn't as good. If we can start these types of interventions at the mild cognitive impairment stage, the outcome is much better.
Fantastic. I think it's important to know all of this because we don't want to incorporate dual task in a bubble per se. We don't want to think that's the only thing. Certainly, if we're treating or training somebody with dual task training on the SMARTfit system and they have untreated sleep apnea, boosting that cognitive reserve or any other motor or cognitive abilities will be more difficult. If they're doing quote unquote homework in terms of a multimodal exercise program on their own, with a trainer, with a therapist, with virtual services, that's going to be even better. If they're socializing, leisure time activities, supporting synaptogenesis and neurogenesis and angiogenesis with good nutrition, preventing polypharmacy if it's unnecessary, preventing pseudo-dementias with over-medication, which is a big issue. All of these things are important. So health and wellness, I think both for fitness, for the rehab clinicians, all of that, we're starting to appreciate that. And the lines are a little bit blurred in terms of who shares that responsibility. But because there's so many factors and because so many people don't hit all of these, it's important to kind of work in an interdisciplinary framework to make sure that we are addressing these. So we could probably spend all day on that slide. And so let's go over how exercise benefits cognition and quality of life. This is for older adults with and without cognitive impairments. Mike and or Rob, please explain to us what the myriad of benefits are for exercise on cognition.
Yeah, I'm going to defer to Rob first on this one. And he may not leave me anything to talk about.
Well, if you look at the research, and we figured this out, actually it was almost 20 years ago. There were some problems in the literature. And about 2003, somebody did a meta-analysis and they said, hey, wait a minute. All of these physical exercise studies, they're improving executive functioning. And if we look at that, all of the research made sense. And so that's what we have seen for the past 18 years. Physical exercise, be it strength training, be it or resistance training, be it aerobic training, be it high intensity interval training, be it Tai Chi, be it yoga, that's what they all find is that it leads to improvements in overall executive functioning, which can be defined as including those things on the screen, including attention, inhibition, problem solving, reasoning, planning, and working memory. One of the things that I think here is important, I just want to reiterate it though, once again, if we improve executive functioning, that is likely to transfer to everyday activities of daily living. And that is the goal. We don't want to just get better at that one task. We want to improve quality of life. And we can do that if we improve executive functioning. And physical exercise, as I mentioned earlier, is by far the most researched intervention to do that.
Fantastic. Thank you so much. And so let's talk about dual task training. So we appreciated that exercise was in that category of physical training, although we also recognize that there's been systematic reviews showing that motor training, resistance training, aerobic training, they all can improve cognition, brain function, and brain structure in both shared and unique ways. But let's talk about dual task training in neurologic conditions. Mike, why don't you take this on?
Yeah, this is so fun because Several of the authors here are very good friends of mine, and I can tell you that it's very important to understand really this very first one is that we get a carryover to single task, and we'll call that a near transfer to single task, even greater when we perform the training in dual tasks. So that means regardless of how protected the assisted living or the in-home environment is for the individual you're working with Parkinson's disease and Alzheimer's disease for this study, and I'll extend it beyond these findings into multiple sclerosis and stroke, but acknowledge this study looked at Parkinson's and Alzheimer's. When training individuals in more complex environments with dual task load, the carryover was better than with single task training for each one of those different presentations. Meaning, if you were to just do single task training, you won't improve someone as much as you will in dual task training. So we look at in gait velocity, we look at it in gait symmetry, in stride length, in balance, and in cognition for all of these conditions that are the two most prevalent neurodegenerative disorders by far. So you really get the improvement across the functionality in mobility, as well as static balance. Can I keep my sitting balance? Can I keep my reaching balance? As well as cognition. So it's superior across all three of those, which is, it's a huge win.
Awesome. And let's briefly discuss this, not forgetting the integration of ADLs here, of how gait, which you just spent a good amount of time on, cognition, the neurologic and neurodegenerative conditions we've discussed, and motor function all interrelate.
Yeah, so this one is actually another good summary of something that we've covered nicely here today. You have two different ways of arriving at being unable to function in a dual task world when the common brain networks are being demanded or commanded in ADLs, in balance, and in gait. And if your cognitive resources are deficient or impaired through the upper channel, MCI, and that could, certainly occur all the way through dementia. Or if your resources are somewhat impaired through the lower channels, more in the mobility area, either one of those mechanisms can be a means by which you're going to arrive at being incapable when the common brain networks are commanded or demanded. So we look at both of those being routes by which an individual can be at risk. And we understand that both of them can lead to that consequence or sequela that land you in the emergency room because either your mobility was impaired and cognition was too demanded, or your cognition was too impaired and your physical capacity was demanded. Either way can land you in the emergency room, hip fracture, subdural hematoma, etc.
Fantastic. Thank you, Mike. And so let's briefly talk about, we now understand the relationships between dual task ability, cognition, ADLs, these different conditions. I'd love for us to talk about how we can actually integrate dual task cost and dual task assessment into our training programs. So let me make sure this is the right video here. I have an inkling that it's not. Give me 1 second.
And Ryan, while you're sorting that out, I want to just take the liberty here to address one of the questions here in the chat. Kurt had asked if there are any studies showing how sleep quality can influence those on the cusp of MCI. And I'm actually going to redouble down into your answer here about lymphatics. And Kurt, as well as everyone, I'm going to actually send you a link to a study that is exactly what you're looking for there. So looks like we've got the video queued up. I'll let you continue from there.
Fantastic. So thank you, Mike. What we're introducing here is the dual task cost assessment feature within the SMARTfit app and the SMARTfit system. This is about a 5-minute video in which we're going to see from beginning to end how we can actually calculate dual task cost among several different tasks. Now, the task that will be shown, the motor task that will be shown here is a sit to stand, but we also have balance assessments, such as the 4-stage balance test, gait assessments, such as the timed up and go or the timed up and go shuttle tests, and other tests for looking at motor function. And we also have a very diverse set of cognitive demands. We'll also see here that there's certain tasks or games selected for this particular task and assessment, but there's a wide variety of other tasks that are both domain specific to different types of cognition, but also different levels. So a beginner, intermediate, or advanced, or what we just call level 1, 2, and 3 respectively. So let's go ahead and see how this is done. Before we talk about this, Mike, did you want to briefly talk about sort of what's considered the gold standard or the most common dual task assessment, the timed up and go cognitive?
Sure, absolutely. So developed by Ann Shumway Cook and colleagues, timed up and go is simply an overlay of a stand up, walk 3 meters, turn around, come back, sit down. Many of you attendees will be familiar with that description being the timed up and go. The cognitive timed up and go, as it is standardly conducted, would involve the individual walking and subtracting a serial 3 subtraction, or 3 from a surprise number that they get at the go or the start. Typically that number is between 66 and 100, and they're asked to participate with both of those activities simultaneously. Hedging back to, or hearkening back to what we talked about earlier, it's a great test, but it doesn't really absolutely capture the participation of the mathematical subtraction, because all we look at is time single versus time dual. But we'll see a few different things in this video.
Thanks, Mike. Awesome. So let's check this out. Certainly, math not being my strong suit, I don't enjoy manually calculating those two things. Of course, we know it's more than just time. So let's see how that's done.
In this video, we will demonstrate a dual task cost test from beginning to end, review the data, retest after 2 to 4 weeks, and then look at the comparison between both sessions. This should take less than 5 minutes in real time. In this example, we will run the sit to stand 30-second level 3 test. The first activity will be the physical only task. The second activity will be the cognitive only task. And the third activity will be the dual task. In the physical only task, the player stands up to strike the center target, then sits back down again. The player repeats this movement sequence until the timer ends to count the total number of complete repetitions. In the cognitive only task, the player will remain in a seated position while striking the correct target, which in level 3 is seek each letter of the alphabet, while skipping 1 letter after each strike. The data gathered will include score, accuracy, reaction time, and the total number of strikes. Finally, we do both tasks together to compare both the physical-only results and the cognitive-only results independently to the dual task results to determine the dual task cost, which is the loss of performance when doing both together. As soon as the test is complete, you will have the option to generate a report. The percentages near the bottom of the report will compare the results from the dual task to the physical-only task and the cognitive-only task. The first percentage shows a negative 25% from the physical-only task to the dual task. In other words, there was a cost of 25% when performing the dual task activity. Then we see the percentages comparing the cognitive-only task to the dual task. Here we can see a positive 5% improvement in accuracy, a negative 41% decline in reaction time, a negative 31% decline in total strike repetitions, and a negative 21% decline in score. A larger percentage of decline indicates a higher dual task cost result, while a smaller percentage of decline indicates a low dual task cost result. If there is no dual task cost, then the test was not challenging enough, and we recommend you retest at a higher level. Over time, we want to demonstrate that the level of the pre-designed programs we decide to utilize are helping to lower the dual task cost. We recommend you retest your client every 2 to 4 weeks to help them see how they are progressing and to help the trainer to ensure the client is sufficiently challenged without being overwhelmed. After the retest is complete, you will have the option to generate a report. The second page of the report shows the growth analysis, where you'll see the percentages of either improvement in green or decline in red when comparing your baseline test to each succeeding attempt performed on this program. For example, we see there was a 0% improvement or decline in the physical-only task. That means there was no increase or decrease in the number of sit-to-stand repetitions from session 1 to session 2. Under the cognitive-only task, we had a positive 18% improvement in accuracy, a negative 8% decline in reaction time, a negative 15% decline in strike repetitions, and a 0% improvement or decline in score. Under the dual task activity, there was a positive 1% improvement in accuracy, an 8% improvement in the reaction time, an 11% improvement in sit-to-stand repetitions, and a 12% increase in score. This last group of percentages demonstrates whether the pre-designed programs we decided to utilize are helping to lower the dual task cost.
All right, so we can see and appreciate the immense detail that is present within this type of assessment. Mike, do you want to comment on why this is so valuable compared to the traditional timed up and go cognitive that you described? Oh, you're on mute there, Mike.
Yeah, there's so many reasons, and I will succinctly say that one of the most important reasons is to be able to identify where the individual is now so that we can program according to what their needs are. A secondary is documentation so that we can prove we're making an improvement. A tertiary, which may be the most important thing, is so that we can engage the participant and show them that they're improving or what we're trying to improve on. So Ryan, we take this material and we can take it all the way from the tactical warrior all the way to the individual who's just looking to try to be safe in their own home, and we can challenge them specific to their needs only because of how we're informed here.
Absolutely. Well, we certainly want to talk about the warrior, but we also want to talk about one of the populations that are extremely prevalent, both MCI and dementia. Rob, why don't you tell us what the findings have been and what the mechanisms have been in dual task in these populations?
Thank you, Ryan. The next two studies are actually meta-analysis. You can often find one study to prove almost anything you want, it seems. So it's nice to have a meta-analysis where they combine the data from a number of studies. In this case, it was 10 randomized controlled studies. And the dual tasking not only helped people with mild cognitive impairment, but also early stage dementia. And that's not something that we always see. So I think that's an indication this is a pretty robust intervention. And we found that dual tasking improved cognitive ability, no surprise there. It improved mood. There could be a physical explanation, a cognitive explanation, in addition to a dual tasking explanation on that. And then in terms of independence and quality of life, it was good to see that it also improved the ADLs.
Fantastic. And, is dual tasking better than physical exercise alone? I mean, with this concept of what's best is really challenging because in a society where we're already obsessed over that silver bullet, we don't want to make it all about dual tasking, but rather that this type of intervention has not just been ignored in many senses, but not translated into something like the gym, for instance, or to the outpatient or inpatient rehab center. And so why is dual tasking so interesting for us to incorporate into our programs?
Well, I think it's just the robust nature of the findings. The dual tasking obviously does better than no intervention. And maybe it's no surprise that dual tasking does better than single physical tasking or single cognitive tasking. But one of the things that's important in this study, once again, meta-analysis with 20 randomized studies, that we want to make sure that our interventions last. This has been a criticism of the cognitive training literature for the past 20 years. Yeah, you might be able to get an improvement after an intensive 8-week intervention, but is that going to help the person in a year? Is that going to help the person in 5 years? So we're always looking at the longevity of these interventions, and dual tasking effects, the improvements, appear to last longer than single tasking effects. So in many ways, it's hard not to argue that dual tasking is better, significantly better than single tasking.
Fantastic. And sometimes I think when we talk about physical exercise, we don't mean all physical exercise. I think what we mean is single tasking, recognizing that yoga could be part of physical exercise. Lots of resistance training components and techniques could be part of, they have dual task elements, right? And so we want to be very clear about the difference between physical exercise and single tasking. Mm-hmm. Any comment on that, Mike?
No, I'm good. I'm in full agreement and acknowledgement of that. I think that's great differentiation though.
And Rob, why don't you tell us more about this image we're seeing here?
Well, I just like this image because, it's one thing to look at the cognitive results, but it's another thing when you see it on an fMRI, that the dual tasking intervention, in this case, a 12-week program. And, if you want to know, how much, that's what a lot of people ask. You do see a lot of these studies, land at the 8 or 12-week mark. But after a 12-week intervention, it actually found we had more efficient functioning of the frontal lobe, the prefrontal cortex associated with attention. So just another way of looking at this, at these findings.
Fantastic. And Mike, why don't you tell us about the value of gamification and subsequently leveling?
Yeah, so really, when we want neurogenesis, synaptogenesis, we want recovery, all forms of neuroplasticity, we know that intensity is one of the most relevant and most important variables to maximize. And how better can we maximize engagement and intensity than when we have the individual tapped to right at that critical flow point where they know that they're being challenged and might be successful, but might not be successful. And then when they can see themselves be successful, we see the dopamine reward. We see all the reward systems that are dopaminergic and otherwise that really circumvent around the basal ganglia are really subservient to the types of gains we're looking for. So as Ryan has shared with us here in this slide, we understand being in flow optimizes that capacity, maximizes arousal, minimizes anxiety, and the rest of the negative attributes from that. If we go back one slide, we look at the gamification principles, and we understand that being focused on a goal is absolutely critical rather than being worrisome about, is my cognition better or not? Did I achieve what was supposed to be achieved? And really, some of this happens when we ascribe the type of leveling that can be done so that we can enter a plan of care, engage with the patient, and they can know what their baseline is. And then we can have this disinterested, unbiased, third-party observer called SMARTfit tell us, did your therapist do a good job with you or not? Wow, I'm getting better. It's not just my therapist's opinion on this. And that's really where people can light up. And it can be a really novel experience that's meaningful and an episodic memory for the individuals that we're working with. And so that can be, alleviating depression and helping them on so many different ways.
Fantastic. Well, now that we know why we're doing it and with who we're doing it with, certainly we agree that from performance to pediatrics to cognitive impairment, this can apply across the entire lifespan for almost all populations. But I think one of the questions is, how are you doing it? What is the programming you'll use for not just the assessment, but the actual dual task training? And so we wanted to share this video that is actually programming that is pulled from 2 recently completed, soon to hopefully be published studies in Parkinson's disease and in mild cognitive impairment, finding that for the mild cognitive impairment study, it was a community-based study that after about 12 weeks of SMARTfit training, there was significant improvements in executive functioning and dynamic balance. And in the most recent Parkinson's study that the dual task training delivered through the SMARTfit system found significant improvements in both motor and cognitive function in individuals with Parkinson's disease. So we were inspired to show some of the programming, not the entire protocol, but some of the programming that was used in some of these studies. And so this does not have audio so that I can explain to you what's happening. We have a variety. When we say multimodal, we really mean it. We mean dynamic balance, static balance, strength, cardio, multi-directional movements. We can see that we can change where what targets are lit up. Of course, we have from that initial video, we have a nice broad view of all the different cognitive tasks that we can employ. And certainly we want to show you the whole spectrum of physical abilities and how it can be scaled from an older adult with Parkinson's or MCI or no cognitive impairment, maybe just worried well, standing on one leg, to an individual in a wheelchair. And while this is a younger individual, we know that older individuals are also sometimes wheelchair or walker bound, and we're able to adapt it to them as well. Being able to have these multi-directional movements, both static and dynamic balance, once again, strength endurance and gait training, all being very important. And I think one of the challenges with dual task interventions is that they're primarily walking based through long hallways with big sensors that don't really translate to the real world, but having things that are more functional, both cognitively and physically in a multimodal construct is what these studies are starting to show, and certainly more research is needed, as always. But it's really encouraging to see these results improving both motor function and cognition, just as we might theorize. So we're really excited to see that there. And so we do have different ways of scaling these activities. We go from low physical load to high cognitive high physical load, and from low cognitive load to high cognitive load. And as you saw from this video, in the very first introduction video that Kathy was voicing over with all the different cognitive tasks available, we can see how we can mix and match these. Now, we also want to follow some of the principles of progressive overload that are present in the resistance training literature, as well as the cardiovascular training literature, and any neuromotor activity. For instance, if you're a dancer, or if you're playing tennis or ping pong, or even if you're doing yoga, you want to advance the practice. You want to play against harder opponents. You want to increase your skills. So as progressive overload is present within all of those different modalities, we also want progressive overload to be present within dual task exercise as well. Mike and Rob, as I'm going to introduce Tom in a second, did you want to say anything about that?
I feel like you've covered it very well. I guess I would just highlight, underscore, and iterate that in that right side of the column, you may not recognize those terms quite so much. Those are the actual SMARTfit categories that represent everything that we are trying to look at in terms of those domains of executive function and beyond. So those are the names that we internally use, and we're sharing with those of you that already own SMARTfit units so that you can recognize those as well. It's so complete, comprehensive, and representative. I'm just pleased to be involved with it.
Fantastic. Rob, any closing words here?
No, I think we've covered it well. Thank you.